Bismillahirrahmanirrahim. So our next question today is a 15-year-old girl present with a 3-day history of persistent severe vomiting associated with an intercurrent vital infections. She has been complaining of tiredness and lack of energy for the previous 3 to 4 months. On examination, she has a blood pressure 80 by 50, pulse is 130 beats per minute, and has increased pigmentation of her buccal mucosa and nipples. Urine analysis is normal. Her serum sodium is 118, uh, which is low, and serum chloride is 76. Which one of the following is the most likely cause of her presentation? So option 1 is Addison's disease. Second is salt losing congenital adrenal hyperplasia. Third is chronic fatigue syndrome. Fourth one is chronic reflux nephropathy. And fifth one is hyperthyroid crisis. Addison's disease, salt losing congenital adrenal hyperplasia, chronic fatigue syndrome, chronic reflex nephropathy, hyperthyroid crisis. So correct answer is Addison's disease. While Addison's disease is uncommon in pediatrics, when seen, it's usually in the adolescent age group. This girl has a typical feature of an Addisonian crisis with vomiting, precipitating circulatory decompensation, with hypotension due to her lack of adrenal steroid production under stress. She also has a hyponatremia and hypochloremia, and with the hyperpigmentation. These features clinch the diagnosis of Addison's disease. Hyponatremia, hypochloremia, and with hyperpigmentation. These three findings, as we read in the scenario, and blood pressure was low, and these features indicate that she is having Addison's disease. Remaining options: salt losing congenital adrenal hyperplasia, chronic fatigue syndrome, chronic reflux nephropathy, hyperthyroid. The salt-losing congenital adrenal hyperplasia is usually due to defect in the enzyme 21-hydroxylase. This predisposes the child to life-threatening salt-losing at an early age due to aldosterone synthesis deficit. Presentation is usually in the immediate neonatal period. Chronic fatigue syndrome usually has a prolonged and drawn out course, and investigation and examination are frustratingly usually normal. Chronic reflux nephropathy may be associated with a salt loss in the kidney, but the patients are usually normotensive and even hypertensive. Hyperthyroid crisis is unlikely to present in this manner, and usually there is associated hypertension. The presentation of Addison's disease may be quite subtle but should be considered in any individual who has increased skin pigmentation, appreciating that there may be other causes of this. As always, an appropriate history is important. Our second question is: a 3-year-old girl has a 3-year-old girl has a frequent episodic asthma and persistent interval symptoms of nocturnal cough and exercise-induced wheezing. Which one of the following delivery methods would be most appropriate to administer fluticasone effectively to this child? This patient is having episodic asthma. This is a 3-year-old girl and having symptoms of nocturnal cough. Here he is. This question is asking about how you will administer fluticasone effectively to this child. Option A is nebulizer and pump. Option B, breath, actuated inhaler, AccuHaler. Option C is a meter dose inhaler. Option D, meter dose inhaler and spacer device with mask. and E is oral suspension. So I think here it will be a D, meter dose inhaler and spacer device and mask. The management of persistent asthma in young children is similar to that of the adults, in that similar medications, beta agonists and inhaled steroids are used. The method of administration, however, must be adapted to the age of the child. Children aged 3 years are unable to use a meter dose inhaler alone or breath actuated inhaler effectively. Fluticasone is not available in oral solution or suspension, while fluticasone can be administered either by nebulizer or by MDI with spacer device. The latter is the cheaper option and just as effective, and therefore would be the first line of treatment for this child. However, in a 3-year-old child, a mask attached to the spacer is required for maximum administration. If she could not cope with this, using nebules with the nebulizer would then be the next step. The decision as to which medication to use is based on the symptoms, and once made, the most appropriate delivery system is chosen and is generally governed by the age of the child and cost of the parents. It would be unusual for a child under the age of 4 years to use MDI and a spacer without a face mask and to achieve optimal administration. So MDI with a spacer device is the correct answer. The next question is mother brings in her 3-month-old infant daughter saying she has noted difficulty in applying nappies. Birth was by vaginal delivery of a breech presentation with extended legs. The baby is otherwise well. On examination, you noted limited abduction of one hip. Which one of the following additional clinical findings is likely to be most helpful in confirming the diagnosis of developmental dysplasia or congenital dislocation of the hip? So 3-month-old infant, she has noted difficulty in applying nappies. Birth was vaginal delivery with a breech presentation and with extended legs. The baby is otherwise well. Abduction of one hip is limited. You noted limited abduction of one hip. So options are asymmetry of the groin crease lines, inequality of leg length, a clicking hip on extension, a jerk while abducting the flexed hip, internal femoral variant of the hip. So the developmental dysplasia or congenital dislocation of the hip can be unilateral or bilateral. Both genetic and environmental factors can contribute. Familial tendency is likely to involve both joint laxity and acetabular dysplasia. Environmental factors include intrauterine malposition, especially a breech with extended legs, and maternal production of relaxin, a ligament relaxing hormone. Shortly before delivery, girls are affected 6 times as often as boys, and the condition is one of the most important of congenital deformities, as delayed diagnosis and neglected or inefficient treatment can occur major crippling morbidity. An observant mother may notice suggestive early symptoms and signs: diminished abduction, inflection of the affected hip in unilateral cases, asymmetrical skin creases of groin and thigh, approaches inequally of leg length, the affected leg is slightly short and rotated externally. Clicking on hip movement may be noted. Each of the above features is suggestive of condition. To help confirm the diagnosis, careful physical examination is required to elicit the positive findings outlined below, for which all infants should be examined to achieve the earliest possible diagnosis. The flexed hip of a young boy should abduct almost to a right angle. In congenital dislocation, it is often stops halfway, as this observant mother has noted. In the procedure described by Ottolini in 1937, the clinician examined the hips for instability as follows: abduction of the child. How to examine the hips of the child? Abduction of the child's flexed hip is performed, the clinician grasping the upper thigh between the thumb in front and fingers behind, while the child's knee are fully flexed and hip flexed to a right angle. Each thigh is steadily abducted towards the examination surface, while the fingers behind apply forward pressure. Positive findings are the reduction of the dislocated femoral head into the acetabulum with an audible and palpable jerk or a clunk. This is a sign Otto-Lani sign of the jerk. This is the clinician who put this sign. This is Otto-Lani in 1937. So option D is correct. Diagnostic test is recommended to be applied to examination of all babies to exclude the congenital deformities after birth. So this is the end of today's session.